Hello guys, I am Deepak Shukla. Welcome to our channel Study Mania. Today let's learn about laryngeal carcinoma. So first let's learn about the etiologies. So what is the most important etiology is cigarette smoking. This is almost the most common cause. So benzopyrene in cigarette smoking. Then we have HPV 6 and 11. Then we have recurrent respiratory papillomatosis, alcohol, previous radiation, and occupational exposure to asbestos, mustard gas, and petroleum. Laryngeal carcinoma is mainly seen in males. Histopathologically, if you see, it is usually squamous cell carcinoma. Okay, so you have seen the etiology, and histopathologically, it is usually squamous cell carcinoma. So, coming to the types of laryngeal carcinoma, so we have supraglottic, glottic, and subglottic. So how you define this area, supraglottic, glottic, and subglottic? Okay, so at the level of vocal cord and 1 centimeter below it, we have glottic area. Above vocal cord, we have supraglottic area, and 1 centimeter below the vocal cord, till the lower border of cricoid cartilage, we have subglottic area. Okay, supraglottic is above the level of vocal cords, glottic is at the level of vocal cord and 1 centimeter below it, subglottic is 1 centimeter below the level of vocal cord to the lower border of cricoid cartilage. So this is the anatomical landmark of the larynx. Okay, so here you can see this glottis, and 1 centimeter below this is glottis, above that is supraglottis, and from 1 centimeter below the vocal cords to the lower border of cricoid we have subglottis. So the most common is glottic carcinoma. Most common is glottic carcinoma, followed by supraglottic and then by subglottic. Here only you just remember that glottis does not have lymphatic drainage, so it will not go to anywhere else. Therefore, it has very good prognosis. Okay, whereas supraglottis and subglottis have lymphatic drainage, so they have a little bad prognosis. Okay, so subglottic is least common carcinoma. So let's see each type of carcinoma in tabular form. So here first we have glottic carcinoma. I have told you this is the most common laryngeal carcinoma, and it is most commonly present at free edge of vocal cord at the junction of anterior 1/3 and middle 1/3. Okay, so you can see here in the diagram it is usually a ulcer. So it can be a nodule or ulcer or thickening of vocal cord. So here the early presentation is with hoarseness of voice. Since glottis is involved, it is a narrow area in adults, so the presentation is hoarseness of voice. Vocal cord fixation occurs late, and if it is occurred, like vocal cord is fixed, then you will have bad prognosis. Since there is no lymphatic spread, so it will not go to some other area and therefore have good prognosis. Here you will see the well differentiated squamous cell carcinoma and are less malignant. The early symptoms is hoarseness of voice. This was about the glottic carcinoma. Coming to supraglottic carcinoma, this we have intermediate incidence, but the most common is glottic. Here the most common site is epiglottis. Okay, so we have epiglottic or exophytic nodule. Okay, here also we have in supraglottic, that is above vocal cord, we have suprahyoid and subhyoid. Usually suprahyoid is exophytic. Okay, and subhyoid is ulcerative. Here we have late presentation since vocal cord involvement is late. Since vocal cord is the nearest portion, it is not involved or it is involved late. Therefore, the presentation is also late. There is lymphatic spread. Therefore, it is spreading to other areas also. Okay, and rich lymphatic supply. So it goes to the upper and middle cervical lymph nodes. Therefore, it is highly malignant and anaplastic. Worst prognosis. Okay, and it is silent until late. Until the vocal cord is involved, it is silent. There is no symptoms as such. Coming to the third one, we have subglottic. Incidence is least common, but it is worst among these three. Okay, subglottic is worst among these three. The most common presentation is in the midline of anterior half. Okay, in the midline of the anterior half. Here we have early nodule and then we have late nodules. So mainly nodules are there. Submucosal nodules will be present. Presentation is usually late. It starts obstructing the trachea. Lymphatic spread occurs to the lower deep cervical lymph nodes, pretracheal lymph nodes, paratracheal lymph nodes. Therefore, other areas are also involved. Therefore, it is worst among these, and these are poorly differentiated. So symptoms, again, it is silent until late. So if you have to differentiate between these three, in glottic you will get the early symptoms, that is hoarseness of voice, whereas in supraglottic and subglottic the symptoms are presenting late. Okay, so this was about the differentiation points between subglottic, supraglottic and glottic carcinomas. Investigations. So investigation of choice is biopsy. You have to go for histopathy examination. But which is the first line or initial investigation? You have to go for laryngeal examination either by indirect mirror or video laryngoscope, that is 70 degree or 90 degree. Then you can go for CECT, that is contrast enhanced CT scan. CT scan, it is cost effective, it is a faster investigation, and since patient can hold breath for lesser duration of time, okay, so we'll prefer this CT scan. Like we want the patient to hold the breath, inspire and hold the breath, so can we see the movement of the vocal cords, so CECT is preferred. Then we can go for MRI. It is more accurate, but it takes longer time, it is expensive, and the patient has to hold the breath for longer time. So in a sequence, first we have to go for laryngeal examination, that is video laryngoscope, then CECT, then MRI. Most accurate is MRI, but before this we'll see the CT scan. Okay, so if you want to know the assessment for the involvement of cartilage and spaces, we'll go for MRI. Okay, MRI is most accurate. Then coming to the staging. Before staging, you just see that you have seen all the points about what is supraglottic, glottic, subglottic, what are the different points in these carcinomas, and what are the primary investigations that will do. Okay, staging of the laryngeal carcinoma. So we have again TNM staging. Okay, it is very important to know the staging because the treatment is dependent upon this only. Okay, but it is very easy to learn. Okay, so we have stage 1 to 4. Okay, right 1, so T1, right 2, so T2, right 3, so T3. It is very easy. So till stage 1 to 3 we have T1, T2, T3, and other things are N0, M0, N0, M0. In stage 3, either T3 or all the T1, T2, T3. But now comes N1. Okay, so N1 is the first time is coming in stage 3 and M0. Now again stage 4. So 4A, write 4A, 4B, write 4B, 4C, write 4C. So it is very easy. Whatever is there, write there, write there, write there. Okay, and follow the previous things. Okay, simple. So in T4A we have T4A, N0, M0, or T1, 2, 3, 4A, all the previous things plus N2, M0. Okay, in T4B, write T4B, all the previous things 1, 2, 3, 4, 5, sorry, 1, 2, 3, 4A, 4B, then write N3, M0. In 4C, write T4C, here any T, any M, and M1. Okay, so this is about the TNM staging. Okay, so N1, N2, N3, NEN. So it starts from 3. So if you write like this twice, you'll remember the staging of laryngeal carcinoma. Now let's see what do you mean by T staging. Okay, so T1, only one subsite is involved and vocal cords are mobile. In T2, more than one subsite is involved and vocal cords are either normal or have restricted mobility. Okay, in T3, more than one subsite is involved, like the same one. Vocal cords are fixed. Okay, invasion of inner pericordial cartilage and involvement of spaces around larynx is T3. More than one side, vocal cords are fixed, invasion of inner pericordial cartilage, involvement of spaces around larynx. In T4A we have local spread around the larynx. In T4B we have distant spread. Okay, so this was about the T staging. In nodes, N0 is no neck nodes, N1 is less than 3, N2 is 3 to 6, N3A is more than 6, and N3B is also more than 6. Okay, so N0, no neck nodes are involved. NV, less than 3 centimeter size of lymph node is involved, and that too ipsilateral lymph node. Ipsilateral lymph. Now coming to N2, we have 3 to 6 centimeters of lymph nodes. Here A, B and C. You can also imagine in the order of severity that N2A will have single lymph node and that too ipsilateral side, okay, same side. N2B multiple lymph nodes or ipsilateral lymph nodes, okay, on the same side. But N2C, okay, it is either single or multiple, or they have contralateral lymph node involvement, okay. So this is N2C. So we have ipsilateral lymph node and then contralateral lymph node in C. So C contralateral lymph node, okay. Coming to N3A, we have more than 6 centimeters, so there is no extranodal spread, In N3B, we have more than 6 centimeters, but there is some extranodal spread. So this was about the node classification. Coming to M classification, M0 is no distant metastasis, M1 is metastasis present. So this was about the TNM staging. So now when you write here T3, T4, T4B, so you should know what is N2, what is N3. So you should be knowing these things, okay. So this was about the laryngeal carcinoma stagings. Now coming to this treatment is according to the stage. Now treatment for the stage 1 and stage 2. Whenever you write stage 1, you know that it is T1, N0, M0. When you write stage 2, you know T2 is stage 2 is T2, same thing. So for stage 1 and stage 2, we have radiotherapy. Radiotherapy is the treatment of choice for primary carcinoma, okay. Aim is to preserve the organ, okay. You have to preserve the speech and voice. Exception: if cancer of middle 1/3 of vocal cord is involved, then the treatment is microlaryngeal surgery. If middle 1/3 is involved, treatment is microlaryngeal surgery rather than radiotherapy, because surgery itself is curative and less risky. Now coming to the conservative surgery that we have, either we have vertical hemilaryngectomy or supraglottic laryngectomy for stage 1 and stage 2. So we go for vertical hemilaryngectomy or supraglottic laryngectomy when there is chances of recurrence or when we need to avoid radiotherapy. So in cases of stage 1 and stage 2, we can go for these surgeries, okay. But this is not for primary carcinoma, this is for recurrent carcinoma. In vertical hemilaryngectomy will remove a part of larynx, okay. So if one vertical half of larynx is involved with subglottic involvement, not more than 1 centimeter, this is the indication, okay, for vertical hemilaryngectomy. Then what is the indication for supraglottic laryngectomy? The supraglottic lesion not involving glottis, okay. Here we have to go for complete larynx excision above the level of vocal cord. But the exception is if involvement of pre-epiglottic space is there, that is it's T3, but the treatment is same, okay. So in T3 also we'll do the same thing even though supraglottis is involved. In stage 3 and stage 4, we'll again go for concurrent chemoradiotherapy for stage 3 and stage 4, okay. In early stage 4, till the time thyroid cartilage is not involved, okay. So in chemoradiotherapy, we'll go for cisplatin, carboplatin and cetuximab. Then in large T3 or T4A with one arytenoid spared, we can go for near total laryngectomy. What is the indications for this? Either there is recurrence, or the patient cannot take chemoradiotherapy, or if there is involvement of thyroid cartilage, T4A, or if there is bilateral arytenoid involvement, we'll go for near total laryngectomy or total laryngectomy, So these are the indications for total laryngectomy. For near total, if it is large T3 and T4A with only one arytenoid spared. If bilateral arytenoid, then total laryngectomy. So this was the treatment according to the stage of the laryngeal carcinoma. So treatment is based upon staging. Staging is very important, okay. Like stage 1 and 2 will go for only vertical hemilaryngectomy or supraglottic laryngectomy, and stage 3 and 4 we go for near total laryngectomy and total laryngectomy, okay. So this was all about the laryngeal carcinoma. Thank you so much.